All right, back with part two of how do dopamine blockers, also known as antipsychotics, work. So antipsychotics or dopamine blocking medications, you can see, are used for a lot more than just psychotic disorders. So obviously these are medications that were first developed for use in schizophrenia, but are often a staple of use in bipolar disorder, although probably should be secondary to classic treatments such as lithium, which we'll talk about in the bipolar mood stabilizing section of the class. Increasingly, dopamine blocking medications are used for augmentation in antidepressants, which has some pros and cons to it. And they're a staple of use in emergency rooms, psychiatric emergency rooms, for treatment of acute agitation and stimulant-induced psychosis. They're also sometimes used off-label for in small doses for treatment of delirium and for treatment of agitation in dementia, although there are some risks that we'll talk about in a moment for that. Now, all antipsychotics, with the exception of pimavanserin, which I'll talk about at the end, are dopamine modulating drugs. So historically, the first generation antipsychotics only blocked dopamine or primarily blocked dopamine. Which differentiates them from the second generation antipsychotics, which also block serotonin 2A. But the first generation or typical antipsychotics or classic antipsychotics, as they're sometimes called, are primarily dopamine 2 or D2 antagonists. And that's symbolized by that red triangle on these illustrations that you'll recognize from your Stahl textbook. Now, these were helpful in that they blocked overactivity of dopamine in the mesolimbic pathway. So they tended to reduce the positive symptoms of psychosis, such as hearing voices or having delusions. Now, the problem was if you overshot and you blocked too many of those receptors, you ended up getting side effects such as extrapyramidal symptoms or EPS, which I'll talk about later on, and hyperprolactinemia. You've got to, in order to hit your target, you've got to get about 60 to 65% of those D2 receptors blocked at least once a day in order to have this antipsychotic efficacy. If you undershoot, you're probably going to have some residual symptoms. If you overshoot, you're going to have these movement disorders, and you're going to have the potential for causing the person to have hyperprolactinemia. So it's trying to kind of get this Goldilocks dose of just the right amount, not too much, not too little. But the problem was with the first generation antipsychotics, they did nothing for improving the dopamine activity in the mesocortical pathway. So if you recall, mesocortical pathway is the connection between the midbrain and the cortex, the wrinkly part of the brain that controls things like cognition, thought, volition. Okay, so what we think of as negative symptoms in schizophrenia, the thought blocking, thought withdrawal, with social withdrawal, social isolation, avolition, really didn't do anything for those. In fact, if anything, it probably made them worse. So when we think about your sort of classic patient in a state hospital, say in 1980, who's on a large dose of haloperidol, probably having movement symptoms and total flat affect, lack of volition, but maybe having a quieting of their psychotic symptoms, that's going to be the result of a classic first generation strong dopamine blockade drug like haloperidol. So you may have knocked out the hearing voices, but you've really stripped the volition and the ability to think easily from that person by blocking those pathways with your strong D2 blocker. The other problem too, you might see that same person sitting in the day room having tremors or having what appears to be sort of Parkinsonian-like symptoms. And that's because their Niagara striatal pathway, which includes things like the substantia nigra portion of the brain, which is implicated in Parkinson's, is also blocked. So dopamine is not able to act there. And then we see these extrapyramidal symptoms. And then finally, that person might be lactating. And the reason why they're lactating is because we've blocked dopamine in the tuberoinfundibular pathway. So that is the connection to the pituitary gland, which controls the release of prolactin. So we can see this increase of prolactin level. Even if the person doesn't begin to lactate, increased chronic prolactin levels are really not good for your bone density. So you don't really want people walking around with elevated prolactin for long periods of time, because they're going to erode their calcium stores in their bone, and they're going to be more prone to osteopenia and osteoporosis. So it's not only an unwanted side effect, because most people that are not having just had children really don't want to be lactating, but also it's not good for your bones. So then come along atypical antipsychotics starting in 1989 with clozapine. Now, what makes an antipsychotic atypical? Well, you notice, so you've still got that D2 blockade, the bottom right corner there, that D2, but you also now have this blockade of serotonin 2A receptors. So this is your classic schematic for a second generation dopamine blocking agent, or an atypical antipsychotic. Now, in reality, most of these drugs not only have the D2 blockade and the serotonin 2A blockade, but they also have all these other receptor activities. So Stahl likes to do these little cartoons to show you where the drug actually has action. And so obviously, probably no med is going to act on all of these equally, but this is sort of the way that he illustrates them in that book. And this makes these drugs somewhat versatile, because depending on what we want to accomplish, say mood elevation or strong antipsychotic effects, we have some choices, and we can learn to make those choices based on the receptor activity of the drug. And so I want to teach you the why and how that this works, not just rote memorization. So that's why I'm going to walk you through this. So with an atypical, we're still blocking dopamine in the mesolimbic pathway. So the attempt there is to reduce those positive symptoms of paranoia, auditory hallucinations, and such. But by blocking serotonin 2A, we're doing something really interesting. So now what we're actually doing is we're causing a release of dopamine in the mesocortical pathway. So that's that midbrain to wrinkly brain part of the brain, okay? And by increasing activity in the mesocortical pathway, we can actually maybe even improve some of these negative symptoms, such as avolition. But we're doing that by this interesting trick where, by blocking serotonin 2A, it actually leads to a release of dopamine in this mesocortical pathway. And that's advantageous to us, because we actually want to help people's cognition and volition, people that have schizophrenia, but we want to dampen down dopamine activity in the mesolimbic pathway. So it's this tricky balance. You want to turn it up in one part of the room, and you want to turn it down in another part of the room, or the brain, if you will. So also by blocking serotonin 2A, we cause this release of dopamine in the nigrostriatal pathways, which, if you recall, control movement, so spontaneity of movement, smoothness of movement, and prevent some of the extrapyramidal symptoms like tremor and Parkinsonianism that we saw in the first generation antipsychotics. So again, this is another part of the trick here, is that by blocking serotonin 2A, we cause dopamine release in another part of the brain where we want it, which is the nigrostriatal pathways, which prevents these movement disorders that we get if we just block dopamine there. And then finally, by blocking serotonin 2A, and also by, because most of these drugs don't fully block D2 on the pituitary lactotroph. That's a great word, huh? So if you look at the cartoon here, so you see that first generation, so that might be a haloperidol, fully blocking these dopamine receptors on the pituitary lactotroph. Okay, when you do that, it actually causes prolactin to release, because these pituitary lactotroph cells have both dopamine receptors and also serotonin receptors. So this is what leads to hyperprolactinemia, galactorrhea, and such. With the second generation antipsychotics, there's a subtle difference. So you see, you still got that dopamine blockade on those dopamine receptors, usually not a full blockade, it's usually a partial blockade. So again, so less likely to generate this prolactin release. But importantly, you also have serotonin 2A receptors on these cells. And by blocking that, you create this balance. So the release of prolactin is influenced by both dopamine blockade and serotonin blockade, and they sort of cancel each other out, if you will. And so what that does is the net result is less prolactin release. So you're less likely to see hyperprolactinemia with the second generation antipsychotics, as evidenced in this cartoon. So in this next talk, we'll talk more about how these things cause side effects, and then finally start talking about specific drugs.